Good evening, everyone, and thank you so much for being here tonight. Greatly appreciate it. And tonight we're going to talk about teaching that resonates and how designing sessions how for engaging teaching of SUD care. Because we've talked a little bit about some other issues, psychological safety, and some other issues, but a lot of this does come down to how your sessions are designed. And as always, we have our disclosure that we don't have any relevant conflicts of interest to disclose for CME purposes. And we'll start with some introductions, and I will let you get started, Dr. Gutierrez.
Hi, everyone. It's nice to meet you. My name's Kevin Gutierrez. I'm one of the faculty in the Department of Psychiatry. Clinically, I see folks for adult outpatient medication management virtually at UCR Health. And so I'm happy to be here and help support this really amazing effort to help kind of teach our trainees how to deliver kind of the best possible substance use care. So thank you for having me, Rosemary.
And thank you so much for agreeing to do it. I think most of you know me. I'm Rosemary Tyrrell. I'm the director of the Office of Faculty Development here at the UCR School of Medicine, and I also hold a faculty appointment in social medicine, population, and public health. And I've been now here at UCR for 9 years, and UCR was my first medical school. So I've learned as much as I can about clinical teaching all along the way. And those who know me know that I always start out with learning objectives. So I hope that by the end of tonight's session, you'll have an opportunity to apply evidence-based instructional design frameworks, and we'll talk about some of those, to select and justify some strategies for engagement uh, it- that support that psychological safety around very sensitive SUD topics. And you'll have an opportunity, hopefully, to design or revise or at least look at teaching cases and learning activities for reduced stigma and so on, and align those strategies with your learner needs and your teaching goals. So we'll talk a little bit about that. And then maybe by the end, you'll be able to articulate a little bit more how instructional design choices influence how learners accept what you're talking about, affect their ability to use their clinical reasoning skills, their professional identity formation, et cetera, within that context. So we're going to do something called a waterfall. Some of you have been in my sessions before, know what this is, but we're going to ask you to think privately about a teaching session, any topic that really stayed with you. And that could be when you were a student, an undergraduate, or later when you were at a conference or whatever, something that really stuck with you. And then write down, not because of what was taught, but how it was designed, how it was taught. And jot down in the chat what to, but don't hit enter. So those of you who haven't done a waterfall before, everybody types their answer in the chat, and then I'll count 1, 2, 3. And when I do that, you hit enter, and all of the answers come into the chat, just like a waterfall. So what was it that the instructor did? How was it structured? What made it engaging? Any of the above, just whatever you want to share with us. And again, this doesn't need to be a session about SUD. It doesn't need to be perfect teaching, just something that's stuck with you. I'll give you a minute to type up your answers in the chat. All right, hopefully everybody had an opportunity. And now I'm going to say 1, 2, 3, enter. Beautiful. All right, we didn't get everyone, but we got a lot of people. We got a few people. So clear learning objectives, not too much material, explained really well, genuine sharing of experience, provided tips I hadn't thought of before, asked participants' opinion, very good, all excellent responses. So oftentimes what we hear from people when we do this activity is, that learners had some agency or choice, that there was a clear through line and purpose to the session, that you were given opportunities to reflect on what you learned, and you felt psychologically safe. Those are some of the answers we sometimes see. So, we're going to talk a little bit about evidence-based design frameworks. So, some of these you may be familiar with, and some may be new to you, but they're just frameworks that you can apply in your teaching however it makes the most sense for you. And the first one is backward design. And some of you, again, may be already familiar with the concept of backward design, but it's especially powerful for substance abuse disorder care because it prevents content dumping and forces faculty to clarify what learners should actually be able to do in an emotionally and clinically complex situation. So often these kinds of topics fail when sessions focus strictly on facts without aligning to clinical reasoning, communication skills, decision-making behaviors, professional identity, and so forth. So this can be a particularly useful framework. And what is backward design? It's a very simple idea. Often when someone is given a course or asked to do a lecture, they begin by planning the activity. So someone says, hey, Rosemary, how would you like to teach a class on teaching and learning theory? And I think, cool. How should I organize it? Maybe I'll talk about different theories using historical perspective. Maybe I'll organize it around influences of those who created these theories. Oh, and I'll have students read this or that, and maybe they'll stage a debate about, et cetera, et cetera, et cetera. I start planning all the activities and the sessions and what it is I'm going to say, what I'm going to cover. With backwards design, what we're uh, what we're trying to do is flip that model on its head and start with the end of the course or the lesson and plan backwards from there. So what does that mean? It's three simple steps. And the first step is identify the desired results. So what is it that you want the students to be able to do or know at the end of this session, rotation, block, whatever it is, year, clinical year, whatever. So that usually translates into learning objectives, whether you write them out formally or you just have them in your head. So by the end of this, I hope that students will be able to do what? So you start with the end in mind. And then step two is what will you then accept as evidence that they can do that or know what it was that you identified in step one. So if you wanted students by the end of this training to be able to take a history and be sensitive to language, etc., around SUD care, then how will they prove to you that they can do that? Probably won't be a multiple choice test. It might be an OSCE or it might be you observing them in a clinical environment. So for some things, this is fairly straightforward. So can the students identify the parts of the brain or not? I can easily create an assessment where I give them an image and ask them to label it. Simple. For other outcomes, identifying what you need for evidence can be a lot more challenging. So is the student demonstrating good patient communication skills around these sensitive topics? Well, that's a complex concept and it involves a lot of subjective factors. So, one person's idea of straightforward communication can be seen by others as rudeness. So, what will you accept as evidence that they have mastered that skill or knowledge? What is it that you'll accept? So now that you know step three is now that you know what you want them to do or to know, and what you will accept as evidence that they can do it or they do know it, now you begin planning your session and your activities by asking the question, what will help the students to succeed in presenting the evidence to me? So if I want students to be able to solve for X, how much time am I spending in the session, giving them an opportunity to work on that skill? If I want students to be able to take a patient history around these issues in a sensitive and culturally, significant manner, what is it that how many opportunities am I giving them to practice that skill? So now you might think about a class activity or an activity you might be doing in a clinical environment that would help prepare students, demonstrate to you what they know and what they can do with the skills that you hoping they learn. So the application here to SUD teaching, it really does force clarity around judgment-free clinical behaviors. It prevents sessions from becoming moral debates or lectures. It encourages alignment between your session design, any case studies that you're going to do, discussion prompts, and any learner assessment. So making sure those things are all lined up together. And it works well across pre-clerkship, clerkship, and residency. So, one example might be by the end of this session, learners will be able to conduct a brief, non-judgmental SUD assessment using patient-centered language. That's clear. It's something that I can assess for, and it identifies, using backwards design. That's step one. What is it I want them to be able to do? The next model is the cognitive apprenticeship model. So this is a different framework, and this works for SUD teaching because it involves tacit skills like language choice, tone, clinical judgment under situations of uncertainty, navigating emotionally charged encounters. It makes these things visible, which is critical for reducing stigma and passing down implicitly through training. So here's this model. So really it's modeling. So the expert demonstrates their own thinking and behavior using techniques like think aloud. And then the next step is coaching. The learners practice the skill with your guidance and then scaffolding. So you gradually start pulling away your support so that they're more and more independent in what they're doing. And I always like to tell people when you think of the word scaffolding, that's like a teacher term, right? I'm doing edu speak now. But if you think about what a scaffold is, it makes perfect sense. Because what is a scaffold? It holds up the walls of a building because they're not yet able to stand on their own. But eventually, you start pulling that scaffolding away when it's strong enough to stand on its own. And in teaching, it's exactly the same concept, right? You're offering them a lot of support at the beginning, and then you're gradually pulling that support away. And then articulation is the next step, where now learners are explaining their reasoning. And I know a lot of you use that technique in many circumstances. Reflection, where you compare different approaches. How is this better than the last time? What worked, what didn't work? Exploration, finding ways to apply those skills in new and different contexts. So again, the application for this kind of teaching, it really makes the clinician language and reasoning explicit and gives voice to that. It helps faculty teach how to think and speak, not just what to know. We spend so much time telling them what they need to know, but we often don't spend nearly enough time telling them how to do the things they need to do. It's an ideal model for case-based discussions, role plays, and clinical teaching. It prevents transmission of cynical or judgmental hidden curriculum messages. So an example of the use of this would be faculty models how to respond to a patient requesting opioids. Learners practice reframing any stigmatizing statements. And then the group reflects on how language shapes that patient's trust of their care. That would be the cognitive model. And this one is, again, a different one, the experiential learning cycle. So, again, this often triggers emotional reactions and discomfort and strong opinions. So, this is Kolb. Their model provides structures so that the experience lead to learning instead of reinforcing bias. Because in emotionally charged situations, we can sometimes rely back on systems one thinking, which is where all our prejudice and bias live. So this is the Kolb cycle. So the framework is first the concrete experience. So whatever that is, a case, a vignette, a simulated interaction, and then reflective observation, what happened, what felt difficult, an abstract conceptualization. So connecting that experience to evidence, to different frameworks, to best practices, then active experimentation, and then applying that learning to future encounters. And around you go in the cycle again by having another concrete experience where you do the same. So this applies to SUD teaching in ways because it prevents emotionally charged cases from becoming very unproductive. It builds in reflection without any form of shame. It helps learners translate their insights into action and action planning for the next encounter. It is especially effective for interdisciplinary groups that might include, interprofessional individuals that you're working with. You might be doing rounding with, other health professionals, not just, students. You might have residents, you might have pharmacy students or whatever in your group. So, some examples are the learners, you provide learners a case that is poorly written, and they read through that and they analyze it. Where are the problems? They can reflect on how they would react if this was presented to them and connect that to your trauma-informed principles and best practices again. And you can ask them now to rewrite that case or use that as an example to plan a future encounter by avoiding some of the problems that are existed in that. And I believe this is the last framework that I'm going to talk about. Yes, it is. And this is the five-step teaching flow. So first of all, the first step is this is the next model and the last one, prime the space. So you want to create an interactive, student-centered, psychologically safe setting. And we've talked about that in some other sessions too. You want to activate their prior knowledge. So identifying their pre-comprehension, what do they already know, their prior knowledge activation. Share with me a little bit about what you know about this so that it's not just that they share it, so they're sort of reviewing it in their head and they're helping build schemas around that. And to engage them meaningfully, which means active learning, case-based simulations, creative projects, etc. And then facilitate meaning making by encouraging and building into your design deeper processing levels, which would include things like analysis, synthesis, deep reflection, dialogue, something that a little higher and deeper level. And then finally, anchor that to practice. So, what is authentic, clinical? How can it be applied? How can you transfer that to real world tasks? So, I have this little cheat sheet, which I call Design Frameworks at a Glance. And I'm going to put the link in the chat. And you've got your QR code there. That kind of just takes those designs that we just talked about. And there's like a little chart that shows like this might be a good option for this type of situation. So I want you to think about some of those frameworks as we move forward. And I'm going to turn it now over to my colleague, Dr. Gutierrez, to talk about engagement strategies.
Thank you, Rosemary. So, as Dr. Tyrell was saying, what we want to try and do as educators, again, who have kind of expertise in a field, then that often medical students or some trainees haven't even seen yet. It's very important that we engage with them in a way that both reproduces kind of accurately what we see clinically, but also encourages them not just to learn by modeling, but rather to see the decision making behind it. So, okay, next slide for me, Rosemary, please. Thanks. So some of the strategies that we use for having a structured case progression, meaning as we kind of present a case to a trainee or to another educator, is that we want the cases to come in kind of bite-sized pieces, not necessarily en masse, like a kind of board certificate, oops, as opposed to some sort of board certification. Oops, I think I may have lost my connection. Can folks still hear me?
Yes.
Okay, sorry about that. And so we want to reveal information. I'm going to turn my camera off and then on for a second. So we want to reveal information in a way that also kind of shows these branching pathways that kind of like decision-making flows that allow people to see the myriad ways that different clinical reasoning and judgment can go. Because often people kind of assume, I think medical students in particular kind of assume it goes one very linearly, but it can actually go very many ways. So when you give information, it helps them slow down kind of their processing. Many of them want to jump to diagnosis, jump to the next thing, just tell me what to do. But instead, we want to kind of give them pieces of information that can slow down their thinking and show them kind of in a neutral way a lot of the different things to consider that can move the case in different ways. It's not supposed to be like a gotcha or like it's some sort of red herring or a zebra case where it's like, actually, you forgot to ask about this rare disorder. That's rarely kind of helpful. What we want to see is that we're giving them pieces of information in a way that's deliberate so that they can kind of chew on them in a way and kind of really chew on that case and before moving on forward. And so what we don't want is kind of snap conclusions, which often tends to happen, I think, kind of more on clinical modeling when we're on the floors with trainees, which is just we're busy, so we want to just say, just learn what I'm doing. This is what I do. You see this, you do this. I think I had a trainee unfortunately tell me that a patient had blue hair, and that dyeing your hair is shows that you have a personality disorder. So we spent some time explaining why that's not an appropriate approach to clinical care, that they're learning these sometimes heuristics or shorthands that often are meant to maximize efficiency, not necessarily to model the correct way that we can actually practice care. So in terms of kind of the language reframing exercise, one of the things we can do when working with cases with either trainees or other going through certain types of cases, case design with other colleagues, is that rather than kind of teaching it as a virtue signaling kind of like, shame on you using that language, I find that kind of when you do have people read cases alongside with you, that encouraging them to see how changes and nuances in language will affect your judgment. So sometimes with trainees, I'll say, if I presented a case like this and I present it this way, and then I change one word, I sometimes ask, how does that change your perception of it? So somebody comes in complaining of something versus somebody bringing someone in, like in a psychiatric emergency room. How does these changing certain things or reframing some of the language help kind of not necessarily bias somebody towards a particular direction. And so when we're reading these cases, and I find that having reading notes alongside medical students and trainees can be helpful, where you show like how previous language carries over, especially in our field of psychiatry and especially in kind of substance use disorders. And so when we analyze and rewrite the clinical language, it's not about necessarily the right answer, but rather that language that the descriptive is prescriptive. That's something I was taught kind of in my humanities background, is that because we are experts, how we describe certain cases is also prescriptive often for trainees. They kind of hear that and they think that that's kind of the one and only answer. But when we show is that there's a decision-making pathway that often comes in, that guides us in the language we choose, but that doesn't always come out in the case writing. And so when we are kind of encouraging engagement, it's helpful to make it a very low threshold to participate, not necessarily putting people on the spot, making it like anonymous or kind of in the kind of waterfall exercise that Dr. Tyrell showed. Another one is something that's, making it accessible through the chat. I mean, I've even had some trainees who keep their camera off and I'll say, just show me signs of life, thumbs up, thumbs down, some sort of emoji, something that is accessible. And so that is a way in which we can kind of encourage participation. So in terms of decision point polling, in the next slide, as we had mentioned, anonymous participation is that one of the things I like about kind of the waterfall method, or sometimes like, I guess the old school way is to have people write it on a piece of paper by themselves, and then all of a sudden they read it out loud. And so before Zoom and before all of that, and what it does is it shows that there's really like a variety of ways to see it. And really kind of when other trainees realize, oh, I thought of it that way too, somebody else did, as opposed to going sequentially, which often people are going to react to, oh, somebody already said that, somebody already did this. And so I think for virtual sessions, these having a very low bar for participation or low, easily accessible kind of path of least resistance model is very helpful to encourage people to participate in a way that's meaningful. And in terms of the case critique, as we kind of encourage people to look at cases as we design them, it's important, much like in substance use disorder, not to essentialize the problem in the patient. So often there's a tendency for folks to kind of ascribe all of the agency to and blame and responsibility to an individual rather than seeing it from a larger sociologic, ecological or eco-social model. And similarly at the case level, rather than kind of blaming a patient or blaming or focusing on individual pathology, we want to talk about how the language in the larger case is designed to kind of shift that kind of encourages people to see that the way we design things is ultimately designed to produce a certain outcome. So based on how we design the case, that's how we encourage people to engage with. So this is where like function and design overlap. And I think one of the things I used to, in one class long time ago, somebody had showed me that, in the design of park benches, they encourage you to sit a particular way. And in certain places, I think in Asia, there are a couple where they unfortunately have spikes on the bench, and that's to prevent people who are unhoused from lying down on it. And so you have to put a quarter into it for the spikes to go down. And so the design, and even kind of they have some of those anti-skateboarding benches too. The design of similar to a case will produce a certain type of engagement with the case. And so we want to make sure it's easily accessible. It's structured in a way so that they can engage and play within those boundaries, but also just encourages faculty, if we're kind of educator to educator, especially training residents to be educators, to show them that in the way we design the cases, it also helps us kind of approach substance use disorder and produces a type of engagement with a case that models how we would engage with a patient dealing with a substance use disorder. And in clinical script modeling, on the next slide, is that when we talk about modeling language and how to kind of talk to patients, especially in our field in psychiatry, we encourage trainees to be very precise with their language, is that often, especially for trainees, they just want to see how to do it. They don't want to do it poorly. I think when I was a student, that's how I felt. I just don't want to do it wrong. And so they often will kind of assume if I model directly what, I'm seeing, that that's the correct version. And there's so much information already, it's very challenging for a trainee who's never been on the floors to even understand that much of the ways we talk, much of the ways we make decisions, and much of the ways we design cases are actually end products of a lot of judgment and clinical expertise. So we need to make those visible to them and make it very explicit, why we're choosing this word, why we're kind of saying it this way. It's something I spend a lot of time talking to trainees about the language they use. And in that way, it helps us prevent any kind of repetition or perpetuation of a lot of kind of biases that we have in the field in terms of like blaming patients, in terms of castigating patients or disparaging them even, because we certainly see that all of us kind of in our training clinically, especially in ERs. But so the key takeaways from this in terms of case critique and case design is that, the design is that the structure and function are entangled with one another. The structure of the case will dictate the function of how individuals engage with it. And so giving them bite-sized pieces, showing kind of an expanding way that decision making can lead to different outcomes, not just one linear path, is very helpful and encourages them to not jump to conclusions or kind of jump to the end product, but really slow down, think about the modeling and the decision making, and to really be precise and intentional about kind of how we approach each case. And by giving them just a little bit of structure, we don't overwhelm them too, which I think giving them a big paragraph makes it very challenging, especially when we kind of use multiple choice answers. We teach, sometimes I've noticed students want to hone in on keywords or you see this thing and it equals this. But for case writing in particular, and for pedagogical purposes, we want them to engage with it, not necessarily squeeze from it a very distinct like pearl or nugget of information. So the next section, I want to talk about history taking. And this is something that I have noticed in my own kind of training and my own kind of being an educator, and especially with medical students, is that history taking, I think, is a very big sticking point for even engaging with substance use disorders. And so on the next slide, what I want to propose or introduce is this concept that's called a relational model. So often when history taking is being taught to trainees, they're so worried about asking the right questions, not forgetting any information. They don't want to go back to their attending and the attending says, "Well, did you ask about this thing?" And I got you. You didn't think about that. So often they look for comprehensiveness and at the cost of accuracy, because the way we ask a question, similar to the way we design a case, gets the answer we want. But as you know, substance use can be taboo. And so the way you ask about it is going to yield the product you want. And so the often what I found is that this model, the relational model, and I'll get into some specific kind of examples of kind of using narrative-driven methods. But I found that rather than looking at psychological models, which are important to substance use disorders, relational models can be very helpful. And what I mean by that is not only kind of at the larger level of seeing from systems level discourse on kind of the epidemiology of substance use and really understanding how larger structural forces influence it. It's also about situating the individual within a constellation of relationships because somebody who is unhoused and dealing with substance use is very different than someone who's affluent and has a lot of support. Very different treatment courses, very different risk stratification. And ultimately, what we want people to see is that we are ultimately helping people also negotiate aberrant or kind of disordered or dysfunctional relationships, both with the lack thereof or the kind of overemphasis of a relationship with a substance. And so we want people to kind of incorporate, when I work with patients, I really try and understand the constellation of relationships they have. I'm very concerned when they say they have no one. And that's really when you can worry because it's challenging to help support somebody without their having any kind of social support or accountability. And so what I like to kind of encourage people to do is not only better understand the individual's patient's relationship to a drug or substance, but also what relationships are being neglected. What isn't there? For social reasons? Are you using meth so that you can stay awake if you are kind of um, if you're someone who is female and unhoused, meth use can be used to help keep you awake so that you aren't assaulted. And so these are kind of things that we need to understand about people's relationship and the function. So what I want to bring up to is something called the recovery model, which is on the next slide. SAMHSA has a working definition of the recovery model. It runs kind of parallel to the idea of sobriety or abstinence. Sobriety and abstinence is outcome driven. We want you to stop using it, stay away from it, doesn't make it into your system. Recovery is from a relational model. It is about helping people reorganize kind of their relationships to both other human beings, to their own health, and also to their relationship to a substance. And in this kind of pie chart here, there's about 10 different components to different things that the recovery model encourages, which is about things like respect, giving hope, being person driven, but I wanted to hone in on the relational component, which is that recovery has to be supported through relationships and social networks. So when they have people, even things like AA, NA, having something rather than nothing is very important. And sometimes when it isn't present, encouraging patients to think about why is that? What is a potential place you could go for that? Or where could we seek other relationships? Because time with a relationship with a person is time you aren't necessarily kind of engaging in any substance use. And so what it does is offer hope to people, support, encouragement, and especially community. I often ask patients, where do you feel a sense of community? And usually I get the answer that I don't. And or I ask, where do you feel like a sense of belonging? And many people say, I don't. I don't know. And so when we do encourage patients to re-examine their relationship to a substance, it needs to be global and really understand like a larger constellation of relationships. Because talking about somebody's alcohol use in one patient is very different with a patient who's kind of socially isolated. And as we know, for a lot of substance use individuals, because of the stigma and the taboo nature of it, tend to isolate themselves and further isolate themselves. So it's important to understand what's there and monitor the development of those relationships. For example, I have a patient, I met with him like a year ago. He's had some very severe consequences to some of his relationships with substance use, including police, having altercations with police, spending time in jail. I saw him when he came out of rehab, and his favorite kind of substance was, I believe, opiates and meth. And so he had lost his contractor's license, his family had abandoned him, and one of the things we focused on was thinking about what did that substance actually substitute for. For him, it was him in his mind, it was an avoidance of certain responsibilities. And over time, a year out now, he's reconnected with his son. He got his contractor's license made again. He now goes to hospitals and kind of lectures, gives hope to other kind of people dealing with substance use of showing this as an example. And part of it is we kind of replaced his relationship with a substance by encouraging relationships within the community. And so he had people who were concerned about it, and he had sponsors, he had friends, and really the relationship with his son was something very important when he reconnected with them. And so the recovery model gives us a different example of the goal, which is to come back to those social supports every time, irrespective of the outcome. So I tell folks relapsing is actually can be part of recovery. Abstinence and sobriety can be, but relapsing can be part of recovery too, as long as you are coming back to those relationships. And that's what prevents relapses from being catastrophic benders. And so that's a harm reduction model too. Um, Lastly, or at least I think on the next slide, we have the 10 guiding principles of recovery. I'm not going to go through them specifically. Um, I think Rosemary, could we see? There was the next slide. So there's a QR code if people want to kind of look at SAMHSA's. They have like a very large PDF with I think it's like 30 some pages with some information on the recovery model. I actually use this language with patients. I actually tell them about these different ways of looking at it. And because they often think that there's only one desired outcome, which is to not use. And so, and when they don't reach that, and this is the problem, is that when they don't reach that, they ultimately use that as reasoning to just fall back into the same kind of practices. And so, if you're curious, you can scan the QR code and look at that. And on the next slide, I want to talk a little bit about very specific questions I use. Oh, were you going to say
I,
something, Rose?
yeah, I just was going to say that I also put the link into the chat for the booklet that SAMHSA has. It's excellent.
Thanks. And so on the last a couple few slides I'm going to present on is I want to talk about how to maximize accuracy. Is that we all know that if you walk into a room with a patient, you say, "Do you use drugs?" Or like, "You don't use drugs, right?" You're going to get the answer that patients don't want to necessarily disappoint you. They don't want to have to correct you. And so that's guiding them towards saying no, because it would be an inconvenience to say yes. And so one of the things that I like to do is I like to build it into just the natural flow of the conversation. So if we're going to talk about different types of mental health stuff, or I'm noticing some symptoms that are distressing, you can use that as an entry point into talking about opening up the door about and called normalizing, where you normalize that some people, when they are struggling personally, will lean on and depend on more on a relationship to a substance. Do you have a relationship to a substance? Now, many patients kind of are a little like they think this is kind of quirky. And one patient has told me this is kind of a strange way to talk about it. But I found that it can be intriguing for patients and they find that they become curious about it rather than like withholding or, a confessional kind of or being apologetic in the way they approach it. And many people will ask, what do you mean by a relationship? And I say, well, however you define it. Because is it using drugs every day? Is it using it this much, that much? I mean, in the DSM, we use kind of certain criteria that show physical symptoms and social outcomes that suggest it. But it's important to understand too how the patient sees their use, because we have all worked with patients who have said they use a drug every day and there's clearly problems, but it's not a problem. And if they don't see it as a problem, there's really no way of kind of helping them to the best of our abilities. And so what I encourage trainees to do is develop a relationship with the patient where they feel comfortable even disclosing it. Because if they're not comfortable, you're not getting the information. And if you're not getting the information, you can't really help. And so I think when we're training medical students in particular, they get to the social history and they go, "Do you use drugs?" And it's like, who would answer yes? And so part of it is, I think, having alternative languages and modeling that to in front of like medical students on different ways to bring it up that makes it that make people curious and encourage them to talk about it in a non-judgmental way rather than confessing to their crimes or confessing to like certain, okay, yeah, I actually use more than that, or I use, I lied, I did this. And so on the next slide, to expand and taking some of the narrative strategies, some of the other kinds of things I use, as I mentioned, was using that term relationship. Not every patient's going to like vibe with that. But I have found that in my experience that people find it intriguing and they feel invited to talk more about it. So I tell people about that. I use some of these kind of cues and phrases, and I'll say, substance, like a relationship with a substance. You like certain things about a drug. There are certain things you don't like about it, just like a person. And so part of it, when I frame it that way, people start to see that we're actually curious and want to know more about their relationship and really understand why they're leaning on a substance rather than castigating, blaming them, or becoming like a detective who's trying to like crack the case. And so language is incredibly important. And so some of the other ways I've tried to encourage students to, again, give them different ways to approach how to have the conversation in order to get the most amount of his like information that's accurate and also maintains a relationship with the patient where they will continue to disclose and feel comfortable with that. And so sometimes one of the questions I use, in your lifetime, what have you ever tried? And they'll look at me like, are you asking if I use drugs? And I say, no, what have you ever tried? And they're like, oh, okay. So, I tried shrooms when I was in college, and I also tried this, and I didn't like that. And you'll find that it kind of opens the door where here we're going to talk, we can talk about substances here, not as like a, oh, dear God, you use drugs, but rather getting them curious about it. And so I even asked them point blank, what do you like about that drug? What does it do for you? Some people said, a patient told me, I need a head change. And I was like, change from what? And that opened the door into understanding what their life is like during the daytime. During the daytime, they're stressed. They also happen to be gender nonconforming. There was a lot of kind of violence towards them and how they present. So a head change meant kind of changing their day-to-day life into a way that alleviated the distress they were experiencing as somebody who presents as genderly, like from a gender perspective, ambiguous. And so um, and the last question, which I find very fun, I think most folks have heard of motivational interviewing before, where you ask patients like from 0 to 10, like, how motivated are you? And whatever they say, you say, why not this number? Why not this number? So they say 0, they say 5, and you're like, oh, I noticed you didn't say any of the other numbers. Why is that? Similarly, I find that this question in particular is, are you satisfied with your relationship to this substance? And I have never gotten the answer yes. It's always, and then depending on how long they kind of wait, you can say, I noticed you didn't say yes immediately. What made you hesitate? It's like, well, yeah, when I smoke weed, I'm pretty tired in the morning. Like I struggle to kind of do it. And so people begin on their own to identify certain downsides in a way. And that's how you unveil them. And it'll be different for every person. So I had one patient who was very kind of like withholding about his relationship to cannabis. He was worried about talking about it. And I told him, I used this language and I asked him, are you satisfied with your relationship? And he was like sitting at there and saying, I really don't know. And I said, that's not a yes. He's like, yeah, it isn't. Um, and over time, he actually came back the next session and said, I thought about what you said. And I realized that I'm so tired in the morning after I smoke weed. And I noticed that like I wanted to do my college apps and I was just so tired. And then I didn't do much with it. I just let him identify it. But over time, he was able to kind of see, does this thing fit into my life? And do I want it to? And so I found that over time, he actually cut down on his own, non-prescriptive from me. And he said, and his reasoning was because he wanted to write the best essays for his college app. But that was something he identified. And I think we wouldn't have gotten there if we hadn't taken the time to really create the right conditions in which someone can talk freely and openly to get accurate information that is also comprehensive. And so that's where I found that these strategies can be very helpful not in a prescriptive way, just showing alternative models, mostly from psychodynamic psychotherapy, of how to approach substance use. I think mostly for mild to moderate cases. I think severe dependence and those issues, I think, are a slightly different kind of phenotype that require a different type of attention. But for most kind of, I think, especially cannabis and ones that aren't kind of necessarily kind of, at least from a state level, not considered criminal, I think that this approach tends to be very fruitful. And so I think the next session, I'll pass it back to Dr. Tyrell.
Actually, I think this is your segment too.
Oh, it is? Oh, okay, sorry about that.
No
So
problem.
for the case writing stuff, oh, so okay, I remember what this is now. So in terms of just asking folks here who all have some educational experience, thinking about the cases you've written, or even kind of like what I've been modeling, the stories you tell, what kinds of or even when you were a trainee, I think I'd like to think about when you were all trainees, what were some of the um, or sorry, when you were supervising people, let's say a trainee is presenting a case to you, and they use something like, for example, I had one patient or one trainee say, "Oh yeah, this patient's father committed suicide." And I said, "Okay." I cite and I said, "Hey, have you heard that this other way of saying that instead of committing suicide, died by suicide?" Does that change how you look at it? And so that example, what I want to show is that what have you seen in your own experiences where perhaps a trainee uses some language that feels kind of like morally charged, or overly blaming the patient? And I'm curious to know, and just from folks here, how did you respond? Did you, correct them and shame them? Did you give them an alternative? How did you approach it when a trainee you see is modeling language that is not necessarily problematic, but also just, I think, both inaccurate and also disparaging to a patient?
You can feel free to respond in the chat or just unmute and talk to us.
I think, I mean, it's been a while now, to be honest, but I feel like I've said, actually, we use this term and this is why.
Mhm. So you gave kind of this is the kind of more like of a consensus that we tend to say this now. We've progressed from that. And that's what I'm hearing from you, Tosha. What about other folks? What have been moments where you hear a trainee presenting something, you're kind of, ooh, you notice something like a language or description that is, you notice can produce a certain outcome that's not safe for the patient or not good for the patient. And what did you do?
I mean, I'll add, to what was just said, I think what's been effective for me too in my learning, and then I see sometimes works in as I'm teaching, is to create as an invitation,
Hmm.
in terms of, sort of speaking about, in medicine, there's an evolution in how we think about or describe things, right? That, have, for social reasons, for our expanding understanding of things. And that, organizations that represent people who have experienced death by suicide in their families and things like that have done a lot of advocacy to think about the impact of language, right? Regardless of our intentions. And so I might create an invitation, if we look at the word commit, what does it elicit, right? And sometimes people will say, oh, well, it kind of elicits like you committed a crime, or and then let's disentangle that, right? And then how does it seem different to you if we say the person died by suicide? How does that reframe what's that happens? What does that evoke for you? And why might have people advocated for that change in language? So an invitation to explore it and seeing how the impact might be. That's what I've tried, and when I've had people do that in their teaching, and I thought it was helpful.
Thanks, Dr. Fortuna. And I can hear from both you and Dr. Yamaguchi that the um, giving it back to the trainee is important about how does this change your judgment? And they kind of start to see how there is kind of pressure to look at a case a distinct way based on the language. And so and sometimes I frame it also as what are the benefits of language this way, but what are the what is also the potential harm in using this language, and really appreciating both and hoping that, in general, hoping that they kind of lean towards a particular side. But anyone else want to share kind of experiences where you're supervising trainees and you've noticed that some of the language they're using or modeling from somebody is language that we find that isn't kind of helpful for proper clinical care, maybe inaccurate or even disparaging?
I just wanted to add something. Obviously, I don't have trainees, but when you were talking about that issue of committed suicide, and you said what does that bring to mind? For me, it brought to mind commitment. And I was thinking, you don't know what was in that person's mind at that last moment, right? So the idea is, I don't know, I thought that was really interesting because I've never heard anybody say death by suicide before. I've always heard people frame that as so and so committed suicide. I think that's very interesting.
Mhm.
I would also be interested in the wisdom of the group on what some of the ways you would deal with that. Even if you haven't heard it, how would you deal with it if someone said, yeah, this junkie came in and whatever, whatever? How would you handle that? I'd just be curious with your expertise what you would do.
I see a hand up.
Yeah, I can't have my camera on today, Ms. Popa, because it looks like my bandwidth is not great, so it alters the quality of the session. I
Mhm.
sometimes summarize the case and model the presentation and emphasize the correct terminology and then explain why the terminology I used in summarizing the case is a better option than the terminology the trainee used. And in that way, it's not necessarily a open criticism, especially for, in a group with multiple trainees. It's just modeling a better way. And then maybe if things are really serious and require a little more attention, I might have a conversation one-on-one with the trainee to further, dive into, explaining a little more and maybe emphasizing a little more, what the potential implications are of, the way they present it.
Thanks, Dr.
Well,
Popa. Yeah, I think
excellent.
that's a. Were you going to say something, Dr. Terrell?
Oh, I'm sorry, I didn't realize I was unmuted. I just said that's excellent.
Mhm. Yeah. Yeah, I think that that's also kind of what I'm also hearing is also not evoking defensiveness in the trainee, which I think is we're always kind of at risk of, which is, I've noticed myself with like when a trainee told me that, oh, this patient has blue hair, so they probably have borderline personality disorder. Part of me got very activated and wanted to kind of chastise this trainee for what I thought was quite disrespectful and also just like clinically unsophisticated. But rather than disparage, like act, really censure this trainee, I said, okay, I'm going to assume ignorance instead of malice or bad intentions. And I'm going to say, huh, where did you learn that? And it's, oh, I saw an attending taught it to me from somewhere. I saw it at this place. Say, okay, so let me the hairdresser thing. So part of it was I think one pitfall is to assume bad intentions from the trainee. And it's called Hanlon's razor in philosophy. It's don't assume bad intent malice for what's actually just ignorance. Someone cuts you off on the highway. It's like, why is this person singling me out? And then it ends up being somebody who someone who's really distracted or really just didn't even see you. So I think that's important too, is that sometimes I think if we do kind of engage in just like censuring or talking down some to a trainee, we can actually fortify some of those bad habits. And they really kind of dig in about and see it as like a personal criticism rather than are trying to kind of help them give the best possible care to a patient. So let me see what the next slide is. So I think if we go to the next slide, so in terms of again, I guess we already kind of talked about many of these, which is again, the language we use is you want to be very careful in terms of, and know exactly which trainees, where they are, and really understanding the context in which they're learning. MS2s have not seen the floors. So they really have no idea what it is on the floor. So what they see and hear from you becomes kind of their reality of what it's actually like. And versus a resident who's actively on the floors and has had some primary experience. We want to make sure that we are taking that into account because our language then becomes the language they use because they're just beginning to develop a language. And I think that another tendency is sometimes to kind of sensationalize and storytell. I'm also guilty of this. But I also emphasize like why I'm, portraying it this way. But I think that sensationalized storytelling can also tends to prioritize our own emotions and what we want out of a case rather than accuracy and what's best for the patient. And I've been guilty of this too, where I frame it as this like, this really frustrating patient who really just didn't want to work with me and you sensationalize it and it really isn't about it's not necessarily about that matched the situation but me expressing frustration at feeling futile and feeling inept. And part of our field in psychiatry we talk a lot about countertransference or how kind of in a reductive way like how patients make us feel and that it's important to address those things and also bring it up that like I some trainees I have brought up with them, I say, I hear a little kind of bite in how you presented that case, right? I noticed you used this word and, tell me more about how, what's your reaction to the patient? What do they bring up for you? And to really situate that and normalize that it's okay to be frustrated with patients, but it's important to make sure that it doesn't obstruct you. And so that's why supervision is so important. It's something we do in psychiatry a lot, where we talk everything to death. And so that's where processing it, talking about it, and kind of the post-clinical experience is very important. And I encourage kind of if there's time for, in other specialties to really sit down and have conversations about how patients made us feel and to think about perhaps did my desire to want to save this patient lead me to kind of underappreciate their own responsibility or did it lead me in the wrong direction? And so that in that case, we put less priority on our own morals and desires and put it more into what's best for the patient and giving them the best possible chances and agency to kind of have the life they want. And so I think we did the don'ts, but if we go to the next slide to the do's, I think we
Okay.
kind of touched on some of these things. Um,
Yeah. I just want to make sure we actually covered these, but yes, I do think that we have. And someone asked in the chat about the slides. We're more than happy to make the slides available to you. So if we rush through something or whatever, you'll have that opportunity to look at them later.
mhm. I also wanted to hone in on one particular. Oh, sorry, we're on the different slide now. So for the do's, in terms of the language we use,
I
we'll
can go
go through.
back if you wanted to point
Uh,
something out.
oh no, I realized I was reading off the do slide, so that's okay,
Okay.
Dr. We
All
can
right.
go to the
I'll
do
move to
slide.
that
Thank you.
slide then. There we go.
Right. Yeah. Has anyone ever heard of it, the kind of second to last phrase there, cultural humility before? Has anyone ever heard of that term? And so it's again, situating language as an evolution, as Dr. Fortuna talked about. What we used to have was cultural competence. Latinx patients do this, Asian patients do this. Not great, overly reductive. The next thing that progressed in cultural competence was cultural humility, which came out of UC Davis from Turbilon and Murray Garcia, who I believe were primary care doctors. And or at least one of them was. And the idea was not about capturing a culture in a list or mastering a culture and knowing, oh, I'm an expert in like dealing with that group of people. Um, that rather than kind of promoting expertise or mastery, we wanted to promote humility, that no one can ever understand a culture entirely, even from being a member of that culture. And so cultural humility is a concept where we encourage individual providers to kind of all accept the limitations of understanding a culture entirely, but also promote a curiosity and almost kind of genuflection or respect for what you don't know, and that it's okay not to know those things. And so, what came later was something called narrative humility, and then after that was something called structural competence. But again, progression of language. And so, going back to the top in terms of um, focusing on behavior, symptoms, and clinical decision points. Like I said before, I find that it's very important to understand where the trainee is in their training. MS2s are just going to model. They really, because they're learning, they haven't had clinical experience. And so when we do describe cases, they often tend to see them as like, that's how it is. That's how the real world operates. But when we pick and we design cases, even when we kind of describe symptoms and present cases, that those are all showing to some extent expertise and choice. It was a decision to frame it this way. So when we do model it to trainees, we want them to see that every single point is a decision, and that we want to encourage them to see all possible decisions, the risks and benefits of each, not necessarily that it's always working out this way or that it's all kind of situated within the individual patient. And so by doing that, we prevent like overly reifying or making overly concrete what are actually very kind of abstract, very challenging and complex situations. And that goes into the next part with incorporating social determinants of health realistically without stereotyping. Now, social determinants of health also come historically, actually, is again, on language as progress. Social determinants of health, or SDOH, was actually not the first conceptualization of those concepts, but rather the second. The first term was actually came out of Latin America from Latin American epidemiologists of social determination of health as a process. So often I find that when trainees appreciate social determinants, sometimes they treat them just like cultural competence. You're Puerto Rican, that's like a risk factor. You're this risk factor. Unhoused, risk factor. But rather than seeing these as larger processes, I encourage trainees to really appreciate that not no two patients are actually individually the same, but they may both experience the same social forces. And so it's important not to reify it in the individual of just, oh, you have this identity, therefore you have this risk factor. But there's a difference between that and seeing that they're in the same conditions, but not necessarily the same people. And that's where I encourage people to see that, when we overly kind of emphasize individual pathology, individual risk factors, or even individual like social determinants of health, that there is the same problem. So it's not about expanding variables, it's about changing equations, changing the way we process these things. And that goes into the next one, which is showing patients strengths. In general psychiatry, we use a deficit model, which is the patient decompensated, or that here are these risk factors, here are these deficits, here are these pathologies. But and this is kind of a shout out to our social work colleagues, is other fields can also approach it from strengths. Like, where was their strength not cultivated? An individual like the patient I had who really lost his contractor's license. He was a hardworking guy who ultimately had a very strong desire to give back. And we use that as a strength of just like seeing that, he wasn't giving back because he was alone and he was isolating himself. And so his strength was not being cultivated and optimized. He wasn't putting himself in the right conditions to really even see that that was a strength for him. So when we do that, looking at protective factors and strengths also doesn't overly ascribe responsibility to the individual. Um, I think the shared decision making one we've kind of talked about, which is that we give patients options, within reason, right? There are sometimes we have to kind of be a little more paternalistic, but with my patients, I always tell them, here's one language to describe our DSM calls it major depressive disorder. And it looks like this, and this. What do you think? Is that how you would describe it. Some people say yes, some people say no. But similarly with treatment planning, we give them options. And I use the phrase with it's kind of corny, and I think many patients have giggled when I use this phrase, but I tell them I'm like a waiter and I'm giving you all the treatment, showing you what's on the treatment menu. Based on your preferences, I may even give a recommendation. I may also take something off the menu. I'm not offering that anymore. But ultimately, it's a decision-making process that invites them to give input. And so that's something especially important when it comes to substance use, that people are capable of doing things and there is a sense of choice and there's not one right way to recover.
Let me jump in for just a second because I was very interested in something you said when we were talking the other day about using the word survivor instead of victim.
Mm,
So someone, is not a victim of child abuse, but someone has actually survived child abuse, right?
mhm.
That is a huge, that I think really comes from that show the strength, the resilience of that individual rather than seeing them as you're forever damaged because of this. I thought that was really interesting point that you had made.
Yeah.
We have next some case studies that we wanted to discuss. And what we were going to do is break into rooms, but I think what we'll do is just keep everybody in the main room. And we want you to read through the case study and then decide what language you think might be problematic, and then we'll discuss. So, so this one, I'll read this one. A 45-year-old man described by staff as a frequent flyer comes to the ED again, saying he needs something for his withdrawals. He admits he hasn't bothered to follow any of the instructions he was given last time and refuses to take responsibility for his addiction. He smells strongly of alcohol and gets agitated when the team asks questions. He claims he's been trying to quit, but clearly hasn't put in much effort. The resident rolls her eyes and asks what he expects them to do for him this time. So, again, this may be a little too obvious, but what stigmatizing or judgmental language do you see? What kind of assumptions do you think people are making here? How might the learner, in this case, the resident, eye rolling reinforce the stigma? And you can read the other questions there. So I'm just interested in what people have to say about this case. And you know me, I won't hesitate to call on people if you don't jump in. So let me hear from somebody we haven't heard from before. How about Dr. Campos? Can you say what you think about this case?
Sure. So I think from the first question, I think they're already saying, he's a frequent flyer or he needs something for his withdrawals. And they're already assuming or saying, he's not accepting responsibility, but they're not really looking into, what's causing this? Why is he coming frequently? I think they're already jumping into conclusions without getting a better history, I would say. Because, like Kevin was explaining, we don't know, does he have family? Does he have good social support? Is he maybe coming in because he doesn't have where to live and he's using this as an excuse to have somewhere to stay for a few hours in the ER? There's maybe more that we need to look into this history and see why, what are the issues behind this patient's condition before we already start, saying, oh, he's here just for this. We'll just give him what he wants and maybe send him home and not really digging and trying to provide that, digging more into what's causing this for him.
Now, these are a couple of phrases that jumped out at me. Oh, that doesn't do very well, but it was, I'm going to take that off because I can't read it that way. You try something else. That he hasn't bothered to follow any of the instructions. If that isn't stigmatizing and blame, I don't know what is. And the other one that jumped right out at me is this one. He refuses to take responsibility for his action or his addiction. Um, Here's another one that I thought was kind of maybe it wasn't as obvious as I thought it was, but which is the when someone says he claims he's been trying to quit, I mean, when you say that, what are you saying? Well, go ahead.
I mean, I think the frequent flyer, I mean, I think we can, that's a real slippery slope one because for a good amount of people, they're not catching like what that meaning is, right? When we're saying frequent flyer. Because I think when we say that, it actually results in our bias and then the outcomes of what we're going to how we're going to engage with this person, right? It diminishes their seeking help as, oh, a frequent flyer. And we could see it in the residents' response, right? Because literally when you say frequent flyer, it elicits, oh, might roll my eyes. Like, what are we going to do this time? This 100th time that they've come. Do you know what I mean? As if
Right.
the person's just, why are they coming, right? We just sort of jump right to, and they're always here. What are we going to do for them? You
Yeah.
know? And it kind of closes down opportunity for real care.
And I think that when you say someone claims, you're implying that they're not being honest. So, I mean, a more neutral way of saying that is he states, and just report, describe what's going on rather than putting those judgmental terms in there. So I think those are, that's one. I'm going to ask somebody else to read this next one. Oh, go ahead, Dr. Popa.
I was just going to mention that the label frequent flyer has some other risks because it basically closes the diagnosis very early. This is a substance abuse problem, and it may not always be that, and we could miss another diagnosis. And the second comment I was going to make is, sure, it doesn't sound like from the vignette here that people are actually trying to engage in discussing substance abuse with this patient. But if they're really in withdrawal, this is not the time to discuss, you know, these topics. It's the time to treat and then, try to establish a relationship with the patient, keep communication lines open, and then, try to, uh, uh, help down the line. And in a way, frequent flyer and claims and all these other statements are a little bit of failure of the system too. It's not only the patient. So I think we have to kind of own that when we deal with these difficult situations.
That's such an important point. Thank you.
I want to echo what Dr. Popa brought up, was this ultimately I read this case and it's discharge. Send them home. There's nothing we can do. And you notice that the resident rolling their eyes, and this is kind of from the supervision and kind of countertransference part, is what are they actually coping with? Is it that they feel futile, that they can't do anything, and kind of projecting that onto a patient? And so this is foreclosing opportunities, as was mentioned, rather than opening up possibilities. And that's where when you write cases like this or you present cases like this, you're ultimately just saying there's nothing I can do. It's not my fault, and there's nothing we can do, and it's the patient's problem. And I did want to share one story that did come to mind. I tell the MS3s when I teach them about psychosis, about the challenges of or the pitfalls of invalidating patients who come into the ED often. So I trained out east at kind of a busy public hospital, and there are many kind of individuals who are unhoused. And there was a case that my colleague was evaluating in the psychiatric emergency room. We call them CPEPs in New York. And so they had an individual. She was kind of a maybe mid 30s Black woman, and I believe she had a diagnosis of schizophrenia. And she usually came in weekly to the emergency rooms, and in general, she would complain of something. And people kind of knew that that was her way of just kind of wanting to hang out away from the cold, and they would kind of let her. And usually she would want to leave, and they would let her go. One day she came in and she was screaming that she's pregnant. And the ED attending proceeded to, and she was saying, help, I'm pregnant. And when they saw the diagnosis of schizophrenia, they immediately restrained her and sent her to the psychiatric emergency room, where the first thing that happened when she entered is her water broke. and she gave birth in restraints. And so, and that was the head of the ED. And so, this is where kind of framing these things have very serious consequences. And so that's an example. And I tell that to the med students. It's a very severe example of just that, you can have a psychiatric diagnosis and have medical problems. Contrary to popular belief, just because you have that diagnosis doesn't mean you can't get pregnant. And so it's an example I show when trying to show that sometimes medicine can sometimes be biased against the patients we see and invalidate everything on the grounds that they're psych patients.
Yeah, and I would also say that, the foreclosing the situation, I mean, that's a very extreme, sort of example of that. But even what you were talking about relationship, I remember working in the psych ED in Boston as well as in New York. But in Boston, I remember a particular woman who I guess at some point, I think people actually said frequent flyer, right? But she was really, she had built relationships. I'm sort of thinking back in terms of what you were saying, relational. She had really started to see some of the normal folks that were there as staff in the psych emergency as part of her relationships, right? As part of her circles of support. And when we really started to look at that and what other kinds of support she needed, even outside of the ED, right? Because the ED had become her community in some ways. That we started to look at these other options, right? And gave her more opportunities to have these kinds of supportive relationships, either through programs and services that helped her recovery. So it just reminded me of that sort of relational piece that you were talking about.
Thank you.
Sorry, you might hear my baby in the background. But I was just thinking as we were talking about this case, about something Dr. Gutierrez mentioned, which is, this giving us an opportunity to talk to the students about countertransference. And I think one example of this is positing, is this language being used? Is this stance being taken almost as a way to protect ourselves as physicians and physicians to be from moral injury? And, what are better ways to cope with that than the sort of prescriptive, the writing people off in this way?
I think from my own kind of experience supervising trainees is to create a space with them, especially in supervision, to kind of share that kind of concern about moral injury. That I'll tell them, yeah, this patient frustrates me too, but let's talk about why we may be frustrated, but let's look at what's really best. And so sometimes I think modeling that, whereas sometimes acting like it doesn't affect you or acting like it shouldn't affect you, that like why are you so reactive or letting it bother you, and we try and normalize it of just giving the trainee opportunities. So you don't force them into supervision, but I kind of check in with some trainees and just say, hey, I noticed that there was a lot of intensity to that last interaction. If you'd like, we can go and talk about it or process it. And I think that that's important to give them those outlets, lest they start to make use of these types of kind of narratives, which are really outlets, as Dr. Yamaguchi is describing, to kind of project what are really just distressing feelings about feeling, futile, feeling incompetent, feeling powerless. And so I think it's important to give our trainees that outlet because that also without it, I think it does promote this type of language.
Okay, well, I wanted to conclude with a few final thoughts. One is just to think about what is one strategy from today's session that you could put into practice in your teaching? So just give some thought to that and what will you take and how can you incorporate that? I think with faculty development workshops, which this is, it's sometimes a lot of information and then we forget to make use of that information. So one of the things we know from our evidence base is that making a commitment to try something makes a difference. So if whether you write it down or you're just thinking about it, I want you to think about one strategy that you might be able to use. And like I said before, we're happy to provide the slides if you've forgotten some of the models that we talked about. I also wanted to share with you some upcoming opportunities that you may be interested in. Tomorrow we have our mentoring mixer, which is a dinner. So it's on campus, it's face to face. And if you haven't been involved in the mentoring program before, please do consider joining us just to learn a little bit about what it is. And the thing about it is, if you want to mentor, you can come and see, get paired with someone, or maybe you would like to be a mentor. And sometimes some more junior faculty feel like, well, I can't be a mentor until I'm like the chair of the department or a full professor. That's not true. There's many, many ways in which mentorship can work. So if you're interested and you can't make tomorrow's session, just reach out to Arena Ethel in Academic Affairs or myself, and we're happy to get you hooked up. We also have a resident as teacher program coming up on the 28th, and that is on Zoom. So you're more than welcome to join us and just contact us if you're interested, and we'll get the Zoom link to you. We also have another virtual session on February 5th. It's part of our Culture in Academic Medicine series, and our speaker for that session will be Dr. Denise Martinez. These are not Office of Faculty Development events, but they're events that I thought you might be interested in. So I wanted to share. The first one was today at noon, so we kind of missed that one. But there's two more coming up on January 21st at noon. There's one on improving health and well-being, honoring culture in treatment and services. And on January 28th, also at noon, there's one on understanding trauma, recognizing and responding to trauma in healthcare. So the Zoom link is there. It's kind of small on the screen, but if you are interested, you can just reach out and we'll make sure you get the link. And also, we want to implore you to please do the post-event survey. And do remember that this is part of the grants requirement. So it's not just us wanting to know what you thought, which we do want to know what you think. And I greatly value feedback on any faculty development sessions because we want to be of service. We want to make sure we're providing you the kind of content that you find useful. So please let us know. But also, it's doubly important for these sessions that we get those survey results. And I also wanted to point out that, if you're at all interested in joining the Teaching Excellence Academy, and this is our flagship program at the Office of Faculty Development, it's a community of practice approach where we take a very deep dive into teaching and learning. And if you're interested, just reach out. I can send you more information. There are actually quite a few people in this room right now who have gone through this program and can tell you more about it as well. And I want to leave some room for questions. And I just want to end by thanking Dr. Gutierrez for the excellent presentation and all the excellent materials that he provided. I also want to thank all of you for coming and joining us tonight. And we know time is a very precious resource, and I'm very honored that you spent some with us. Now I'm going to stop sharing so that if you have questions or have any further comments you want to make, we can see each other a little better.
I mean, I have no questions. I just want to comment and again say thank you so much for, this session has been really excellent and I think very thought-provoking. There's some, concepts there that I've thought about, but I think our discussion together has, you know, I think that's the point, right? As we talk about these things, as we reflect on these things, right? We deepen our understanding, and I think it's a great modeling for how we can teach and engage in this kind of conversation with our trainees. So thank you very much. to the both of you for a wonderful session.
Thank you so much. Any other questions or comments? All right, well, with that then, I'm wishing everyone a wonderful rest of your evening, and I will hopefully see you next time when we will be doing one on assessment, and hope you'll join us for that as well. Bye-bye, everybody.
Thank you. Bye bye.